Thank you, Kim, so much for such a kind bio reading there. I mean, man, she made me sound like I was really something. I hope that I can live up to that for you guys. Okay, let's get started. So the learning objectives, we're going to define the role of peer recovery support specialists. We're going to understand the training and certification process. Shawn from the state is going to line that out for us. Develop a shared language between peers and healthcare staff, and also describe what a recovery community organization is. And we have representation over here from Divine Intervention. Next slide. Okay, so what is a peer recovery specialist? Please raise your hand if you've ever met, besides today, a peer recovery specialist. Okay, we've got a couple, but there's still a lot to be learned. Absolutely. I mean, it's not new to the United States, peer recovery specialist is, but it came to Arkansas in 2017 is when it came to Arkansas. So my husband and Shawn both were one of the original supervisors in the state. So Shawn, do you want to say anything about the origination of peer support in Arkansas?
I don't know about the origination. It came here in 2017 as far as a quote-unquote movement. We've had peers in the state of Arkansas in certain organizations, but they were not labeled as peer recovery support specialists, but that was the job functions that they provided. But as far as it being a profession in our state, started in 2017.
So there's some criteria needed to be a peer recovery support specialist. Number one, you have to have lived experience with substance misuse. And you have to have at least 2 years clean. And we'll get more into the specifics of the credentialing, but a peer support specialist is a person living with the disease of addiction or mental health diagnosis who has experienced and maintained the healing process of recovery. So experienced and maintained are the key words there. You have to maintain it. We don't accept people that are, if you relapse, you have to go back through the program. You have to have 2 years of sustained recovery. A person who offers support based on shared understanding, lived experience, respect, and mutual empowerment. A person with strong personal connections to the recovery community. That is key in our profession. You have to know what your resources are. We are non-clinical. We are not clinicians. We are not here to replace clinicians. We are here to be a support system for those in recovery and also to bridge the gaps. We have to role model recovery, be an advocate and a resource broker. Go ahead. So the roles and responsibilities, the main way you can think of a peer support specialist is a connector. That resource brokering is our main job. People are able to, with their lived experience, connect with a peer, connect the peer with him or herself, connect the peer with staff, connect to treatment services, and connect to the community resources. So the core competencies of peer support, our slide is a little jacked sideways here, but that's okay. It always has to be voluntary. And I've heard a couple of the other presenters talk about this. If someone's not ready to get into recovery, we can plant that seed and we can give them options, but it's up to the individual on when they're ready to take the path. You can't force somebody into recovery. For many years, my family tried to force me into recovery. It just doesn't work. It may work for a short amount of time, but until I take that initiative myself, it's never going to stick.
And I can tell you from experience, what does that look like in an ED? Well, what that looks like is a peer walking into the whatever room the patient might be, and I'll use the word patient for today, but we refer to them as peers because they are our peer. And it's just introducing, like I would introduce myself. Hey, my name's Shawn McCown. I'm a peer recovery support specialist. And I would say all that means is I'm a person in long-term recovery from a substance use disorder. And I would love to have a conversation with you. Would you be open to having a conversation? That's how we make sure that all of our services are voluntary, is I have to ask that question. Hey, would you be open to having a conversation with me about substance use disorder? You know, and them knowing that I have that lived experience of a substance use disorder really kind of lets the walls down and lets them kind of take a deep breath and say, sure, let's have a conversation.
So we are always going to remain hopeful, open-minded, empathetic, respectful. We're going to facilitate change. We're going to be honest and direct, mutual and reciprocal, equally shared power. This is another really important part. We are not coming in as an authoritative figure. We are always going to be on their level, and that's what makes peer support so effective. If you come in and someone feels like you're above their level, they may be intimidated or feel stigmatized, or all of those things. So if they come in and they realize that they're talking with someone who's actually been in their shoes before, a lot of times they're way more open to sharing their experiences with you and what's really going on with them. You're good. The last three: strength, focused, transparent, and driven. Go ahead, Jenny. Thank you. So let's talk about what a peer can and cannot do. So we can identify goals, assist with treatment planning, coaching, life skills, referring resources, conducting recovery groups, assisting with discharge planning, conducting individual sessions, like one-on-one coaching sessions, and then transporting to the doctor's office, pharmacy, appointments, et cetera.
And I would just say, all of these are based on your agency guidelines, okay? So what that looked like where it says transporting to the doctor's office, I might as a peer be able to do that. But if my agency doesn't allow that to happen, then that's something I can't do because my agency guidelines stipulate that I can't do that. But it is something that we are able to do as peers that is different than clinicians.
Yes, always fall back on your agency guidelines. Do you want to go over the cannots, please?
Yeah, what we cannot do is we cannot offer any type of therapy. We do not do medication management or psychosocial evaluations, diagnostic assessments, psychiatric services, or therapy groups. And we have been asked to do all of those, okay? And I'm just, being upfront with you. And so that's where we have conversations with the staff to kind of let them know, hey, these are things that we cannot do. I've been asked to give drug tests before. I've been asked to do a psychosocial. I know what that is. And I've been asked to do those, and I have to just kind of let them know, that's not my scope of practice. That's not what we do as peers, because that immediately puts me in a position of authority when I'm talking to someone. So those are just some things that we cannot do. And that's one of the major challenges for peer, and I won't really get into that, but when we first started in 2017 and the movement started, everybody thought, well, they're not going to replace me. And our whole mission and what we were trying to say is that's not what we're here to do. Okay? We had a lot of, I say, flack from counselors and social workers about, well, they can't do trauma. We can't do any of that. And we don't want to do any of that. Okay? We just want to be a part of the support team to be able to help someone survive and live a life of recovery. So.
Okay, so let's talk a little bit about the benefits of incorporating peers. Number one is going to be the lived experience. Like I was mentioning a minute ago, that instant connection that we can make because of the shared experiences in life.
Number two, building trust. We've talked about stigma today. Well, those of us who were people with substance use disorder, we also have stigma. And we have stigma toward the medical community. Okay? But all they want to do is this, they want to make money off of it. We have all kinds of thoughts. Okay? So one of the things about building trust is I get the opportunity to have a one-on-one conversation with someone who might be struggling with a substance use disorder. And I can use my lived experience of how useful and how much difference someone in the medical field made for me. Okay? So it helps build that trust, one, between me and the peer, but also that patient and the medical staff. If I was okay with having conversations with them, and I've turned out pretty good so far, maybe I will meet with them. I say so far because I live one day at a time. Y'all caught that probably. Did you say something? Yeah. So, but it gives them that visual and that knowledge of, well, okay, I'll meet with them. Where before that wall was up and even if you did meet with them, they weren't going to share anything with you. Now they might because it worked for me.
Just like that question someone mentioned earlier, have you used any illegal substances? And they say no. Well, if it was somebody that had used before, they might tell us yes. Right. But if it's someone that has not, they would probably be worried about getting arrested or somebody calling their PO or, all that paranoia that happens. So the next one is reducing stigma. Because we are immersed in this world all the time, we are really up to date on the trends on language and stuff like that. So us being able to be there and be a change agent for the facility is instrumental.
Definitely. Supporting recovery goals. When you're new into recovery, and I can use an example of when you go into an emergency department and you had an overdose and you're ready to stop. One, you really don't know what goals to really set for yourself. But when you can sit down with a peer, and that peer does not set those goals for you, but is trained to be able to pull those goals out of you. And then once those goals are out of you, they can kind of help them along that process of achieving some of those goals, whatever that might be. Okay? So it's really, really, really beneficial for a peer early on to be able to really help that individual set those goals and show them that those can be accomplished.
Next one is navigating systems. Oftentimes there's so many barriers to getting off of the drugs and just not even be able to see past not using, let alone getting your life back on track. Having someone that's been there and done that can walk you through the system is really important and put your mind at ease that it is possible and you can see it happen in someone else's life.
And improving patient outcomes, I can give you an example of that. I worked inside of a treatment provider that was inside of a hospital in Little Rock. I still work there part-time. But their national average for AMA rate, against medical advice, for their organization, because it's a national treatment provider, was 21%. And the national average is about 20% AMA rate. Well, we have, at that facility at the time, we had 9 peer specialists working there. And for the entire year, the AMA rate for our facility was 7%. And it had gone from 21% to 7%. And that one, we were the only facility in their organization that was that low, right? And it was contributed. We were the only facility in that organization that had peer recovery support specialists working for them. So we have that unique ability to have those conversations that they may not have and be able to keep them longer in treatment to give them a better success rate.
Improving patient outcomes. So again, just having that partner to walk with you through the process. Enhancing cultural competence. Understanding the diverse backgrounds. It all seems to lead back to that lived experience. Someone having been down the same road that those people are going down. That's really just what stands out the most to me here. And then cost efficiency. To reduce that revolving door. Seeing those people come in over and over for the same reason. The ones that irritate you because they're back again and they didn't change their lives. Incorporating peer support could change that for that person. And it would make your jobs easier in the end too.
And a great example of that is insurance, no insurance, providing resources to individuals that are underserved. I can remember wanting to stop, but I didn't have any resources to stop. I mean, I ended up going to a state-funded treatment provider because I had absolutely no money. And that's one of the things, the power of a peer. We can have those conversations with those patients that are in the EDs or in the clinics and say, it's okay that you don't have any insurance. We have all these resources available for you to continue, to get into recovery. So it's not limiting. We don't limit their services.
Peer support also goes beyond just helping someone find a path to recovery. It can be helping them get on food stamps. It can be helping them get the insurance they need to get the services they need. It goes far beyond just...
Driver's license.
Driver's license is very common. Birth certificate. So it's after lunch. Everybody gets kind of ready for a nap after lunch. So we're going to do a little bit of an activity to energize everybody. That's only you, Casey. Okay, we need 4 volunteers. Come on, guys.
You don't have to say anything.
Not only peers. You can come here, but we need some other volunteers. No peers? Okay. Hang on, we'll use you in just a second. Sit right here. Don't leave me. No, don't leave me. Okay, come on. He changed his mind again. Y'all aren't off the hook. We need more.
Yeah, really. We're not done. I need 9 people who feel like they have a baseball arm or just want to throw something.
Who wants to throw something? Stand up. 9 people. There's one. Come on. Come on. Come on, Jenny. Yeah, you can kind of stand in the background. Don't be shy. Come on up.
Each of you guys have 3 sheets of paper, correct? And also say the same thing. I want to go from here this way. I want you to tell us what your sheet of paper says. What do you guys think those are? Stigmatizing language, stigmatizing labels. Exactly. Now, what I need each of you guys to do, it looks like you already started, is take one of those sheets and wad it up into a ball. Okay, let me get out of the way.
Yeah.
Okay, now, please protect yourself and don't let anything hit you. Okay? On the count of 3, I want you guys to throw. Oh, on the 1, 2, 3. Block it. Okay. Now I need someone from the audience who wants to be a hospital administrator.
Y'all still aren't off the hook. Come on.
We got to get 7 more people. All right. I want you to hold that
Come
up
on.
and
All you got to do is hold the
stand in front of
sign.
them.
Come on up.
Who wants to be a therapist? Therapist, stand in front of them. Doctor, y'all stand right here in front of them.
Stand in front of the...
Stand in front. Pastor, who wants to be a pastor?
Here, I'll be a pastor.
All right.
No, give me that.
Wow. Nurse.
Y'all are hiding back here.
I need another nurse.
Come on, we need a nurse.
And I need a counselor. Who wants to be a counselor? I need one more person. Come on. There we go. Thank you. Now I want you guys to get a little closer. A little closer. That was kind of some far throws. You come on up here. Yeah. You stand up here. Okay, what this is an example of is this is your typical medical staff, okay, that would be taking care of the peer patients that are in the back, right? Okay, this is the traditional staff. So what I want you guys to do is take that second sheet of paper, wad it up, and I want you to throw it in a way that gets past this group and hits the peer, okay? Your job is to block what comes your way. Okay? Don't let anything hit the patients is what your jobs are. Okay? 1, 2, 3, go. All right. How many we have left? 4? All right. I know you don't want to, but we need y'all 4. Y'all 5. If you guys can come up here. And I want y'all to stand in front of this team. Come on up. Come on up. Stand right here in front of the traditional. Now, as you guys can probably imagine, these are our peer specialists. Okay, so now we have peer specialists, our traditional medical staff, and then we have our patient peer, right? What I want you guys to do is the same thing. Make sure nothing hits those patients, okay? Block everything. You guys just keep doing the same thing, okay? Wad that up, wad that sheet of paper up, and on 3, try to hit the patients in the back. 1, 2, 3. Thank you. Everybody give yourself a round of applause. Thank you. Okay, as you guys are taking your seats, I want to explain that exercise to you. Those those 4 that were the patients, how much did you guys get hit when there was nobody in front of you? Quite a bit? Y'all 4 that were the patients? Got hit quite a bit? What about when you had your traditional medical staff? Did you guys get hit with anything? I think I saw you guys get hit. A little bit still? What about when you guys had the peer specialist and the traditional medical staff?
A lot
No
less.
hits? Okay. Hopefully that provides an example of what a care team can provide for the patient and the importance of peer specialists being a part of that care team. It's another level of support and protection for those patients. I know it's a little fun exercise, and we got to get up after lunch and kind of get our blood flowing, and that was one of the reasons why we did that. But the other reason was to give you a visual example of the power of a peer can provide as a part of the care team in a clinical setting and in an ED. It makes a huge difference when you have all that protection in front of those patients, okay, rather than just a few people that are currently doing that, okay? So hopefully you guys were able to see that.
Next slide. There we go. Okay, so these are some statistics from a North Carolina healthcare foundation that has implemented peer support into their emergency department. I know that stats can be boring, but I wanted this to be up here so that you can see that this is working in other parts of the country.
Did you want to point anything out here?
We're going to send these slides out to everybody so that you can have this to take back to your teams and discuss what all you've learned and anything that you thought was pertinent.
I do want you guys to look at this one right here. Total hospitalizations. Year before peer contact, 2,477. After peer contact, 1,086, 56% down.
That's a dramatic difference.
Right. Can you imagine how much that hospital is saving from, I guess we call recidivism, returning back to the ED? Those individuals, there's almost 1,400 individuals that did not go back to the ED. Okay, so that gave the nurses and the doctors and everyone in that ED staff the opportunity to help someone else. Okay, whatever that was. So just wanted to point that one out.
Okay.
Go ahead. All right, peer credentialing certification. The Arkansas peer model of peer support is different than any other model in the country. When this was designed, it's not that we wanted to be different, but we wanted to create a career path for peer recovery support specialists. Not just one level, and this is what it's going to be for the rest of your life. To give you an opportunity to kind of grow. So that's what we created. If you kind of see, is number 1 is a PIT, peer in training. That's who you are. That's, I guess, what you're labeled when you come out of our training. Everyone is considered a PIT, a peer in training. All right? Then you have a peer recovery specialist, which is PR for that. That's after you take your certification exam. Okay, you become a PR. Advanced peer recovery specialist is the next level above that. We provide more extensive training, more public speaking, advocacy, some specialized training for our peers to be able to kind of get up and do the things that we're doing today. Okay? But that also requires much more additional training, much more continuing education hours, and then you have to take another work experience. Then you have to take another certification exam for that level. And then you have peer recovery, peer supervisors, which is what we call our top level in peer support. Okay, that allows you the opportunity to actually supervise other peers in the state of Arkansas. We have to be a peer in the state of Arkansas, you must be assigned to a peer supervisor. You cannot practice as a peer recovery support specialist in our state without having a supervisor. Okay, it's kind of a level of protection to make sure, as a PIT, you learn how to do peer recovery the right way. Okay? But again, that's more continuing education hours, that's more work experience hours, all of that. And then you have to take another certification exam to be able to be considered a supervisor.
Can you go into the training just a little bit to talk about, okay, this piece may be doing that, but to talk about the ethics that we have to follow, that there is actually training done on ethics, and there's continuing ed hours over ethics, there's work experience needed for each level.
And, oh, by the way, we did not say this, but if you have any questions, just ask.
Yes,
Okay?
jump in.
Yeah, just jump in. But what Megan was saying is, we have a code of ethics for peer recovery for Arkansas. It's over 7 different principles about conduct, professionalism, confidentiality, all of that. We have ethics over that. We also have a supervisor code of ethics, which is separate from all the other levels of peer support. It's kind of like that next level that you have to be able to provide. But we have specific requirements for ethics. Like you have to get 6 CE hours for ethics to be able to do your certification. So you can't just get your CEs in anything. You have to actually get 6 to get for ethics. We have ethics trainings every year for peer support. We have professional development training every year for peer support. But this is kind of how it all works. DIPSQA, which is the department that I work with, I issue every single PIT letter in the state. So it comes through my desk, my computer, and I send them out. So I have to know if they have a supervisor or not. I won't send a letter out unless they have a supervisor, because that letter gives you the ability to work as a peer specialist in the state. If they're a peer in training and they don't have that letter, they cannot work as a peer. Okay. Oak Tree is how we track our supervision. It's a software company that developed our supervision tracking. So that's how we track all of our supervision, our CE hours, all of that. So the PIT, as they're going through they submit all their continuing education. They have to submit all their work hours, and they are also required to get 25 supervised hours. Okay? What is that? Well, what that is they have to attend what we call supervision, that their supervisor provides them. Okay? It's education on how to be an effective peer recovery support specialist. Okay? It's answering questions that they might have at their place of employment. Okay? Scenarios that they might go through. But all that's supervision. And then I monitor and I approve all of that. I either approve it or I deny it. Okay? If you want to go to the next slide. Okay. Everybody understand how that, I want to make sure you guys know how that works, that it's not just you go through a week-long training and I'm a peer now, here I am. Okay? I mean, you've actually got to do the work. You've actually got to put in 500 work experience hours. You have to, actually do 46 CE hours. Right? 6 of those have to be in ethics. So it's a process. It takes time. So it can take up to 18 months to 2 years. We give everyone 2 years to reach that next level of certification. So.
Thank you, Shawn. So let's go over some terminology that's commonly used today. Substance use disorder. I think we all know what substance use disorder is. You'll often see it just SUD. Opioid use disorder, OUD. Medicated assisted treatment, MAT. Naloxone. Everybody know what naloxone is? Narcan? Yeah? No? Maybe? Okay, it's the reversal drug that you use if someone is in an active overdose. You can give them Narcan. And y'all are all getting free Narcan today, by the way. Harm reduction. Ooh, this is a heavy one here, harm reduction.
Healthy debate there.
Yes, very healthy debate. So when you hear harm reduction, what do you think? I need some feedback from the audience. When you hear harm reduction, what do you think, peers? Needle exchange. Everybody's mind goes there. Why? It's like the worst of the worst, right? It makes you think, oh, you're giving them free rigs to use so they can go get high. Yeah.
Anybody else?
Did you know that peer support is a form of harm reduction? It is. It is. Seatbelt, harm reduction. Go Misty. I love it. Love it. So there's much more to harm reduction than just what pops in your mind when you
Fentanyl
think of.
strips,
Yes.
that's harm reduction.
Recovery. What does recovery mean? What is recovery? How do you define recovery? Is there an end goal? It's a good question, isn't it? Okay, let's go on to the next slide. We're going to circle back around to that in a minute. The opioid epidemic. So nearly 80% of individuals with an opioid use disorder did not receive treatment of any type. Did you guys know that? 80% of people that need treatment don't get it. In 2021, 94% of people aged 12 or older with SUD did not receive any treatment. I just think those numbers are staggering. There is an opportunity here for all of us to do something different and to make a difference. And it can be something just as small as having a conversation.
I want to give you guys an example. You guys are in the emergency departments and clinics. When I worked at UAMS for a little while, and you guys, I don't know if you've ever been to the UAMS emergency department, but it's huge. It's like, got like 60 some rooms, and it's just, they told us, hey, these are the things you look for. And if you see these things, approach the patient, right? Well, we were missing so many people because they didn't have all of those check marks, so to speak. Right? So this 80%, I could definitely see. But as time went on, we changed what we were looking for as peers. Okay, so if you came in with any type of chronic pain, you came in with any kidney issues, any liver issues, any back problems, anything, we were going in your room. Okay, so it really changed the number of people that we were able to talk to and to get to treatment. I remember the first 6 months we were doing this, it was like we had gotten like 32 people into treatment. That was it. And after we changed what we were doing, the next 6 months we got 112 people in the treatment. Because we weren't waiting for them to self-identify. We just went. And we would go into rooms that they may have been there had nothing to do with any disqualifying things that we might have think they may have had a substance use disorder. And would just literally walk in there and, hey, I'm Shawn McCown, I'm a peer recovery support specialist. Have you heard of the opioid epidemic that's going on in this country? They'd be like, no. Or they'd say, yes, I sure have. Man, I'd love to be able to talk to you about that if you got some time. They got time, they're in the ED, right? So that's what we would do. We would just start talking about the opioid epidemic. And sure enough, they would, after some conversation, they'd be like, well, my nephew, or, hey, my uncle. And it really opened up the door to be able to, hey, well, here's my information. Pass this on to your nephew or pass this on to your uncle. And we would get phone calls from them when they were ready.
Yeah, it doesn't have to be the direct link with the patient that's in there at the time. It could be a family member that they know. Right,
but 80%, I definitely saw that for a long time until we started changing what we were doing, and we were able to, really talk to a whole lot more people. So that doesn't shock me.
Next slide, please. Okay, Arkansas is second in the nation in opioid prescribing rates. These are just some more state-focused statistics. 3 out of 10 adults say someone in their family has been addicted. Drug overdose in Arkansas in 2022 reported 591. So let's think for a minute, the revolving door where that patient keeps coming in. You see the same person coming in over and over again. And I said we would talk about this again in a minute. What if the peer was available? How would that change the situation? Can you see, after we've had a little bit of conversation about this, how that might change the outcome of that situation?
And I want to make sure you guys understand, we're not coming in here and saying we're the answer. We are a part of it. Okay? We want to be a part of your team. Okay? I just want to make sure that you guys are really aware of that, because we're up here telling you how much of a difference peers make, and we do. I firmly believe that. But we're not the end all. Yeah. Okay? We're just a part of the process. Okay?
An extra tool in your toolkit. But
I think we're a vital part of the process that is just missing because of the lack of education of what we can provide services for. Okay? So it's like, what if a peer was available? We talked about that just a second ago, about changing that recidivism rate. You guys saw that slide where 1,400 people didn't come back to the ED, after they had peer support in there. So you can see the big difference.
Next slide. Okay, peer recovery community organizations. What is an RCO? So an RCO is an independent, nonprofit organization that is led by peers. It's recovery-focused community education and outreach, and the sole mission of an RCO is to mobilize resources within and outside the recovery community to increase the prevalence and quality of long-term recovery from mind-altering services. Next slide, please. This is Shalinda. I'm going to let her share a little bit about divine intervention.
Hey, I did a real good job on that picture, didn't it? You like that? You all can do this on this app that I have. No, this one. My name is Shalinda Woodbright, and I have an RCO in, I guess I don't talk loud enough, even though I'm from the backwoods. I'm just messing with you. All right, so my name is Shalinda Woodbright, and I am from Jonesboro, Arkansas, and we have a RCO, which is a recovery community organization called NEA Divine Intervention. I have brought majority of my peers with me. What we do on a daily basis is we have a community that's not just open to peers, but it's open to the whole public. Families, employers, whoever. If you walk in our office, we welcome you. What we do is we help individuals with everything that they pretty much talked about. Like if they walk in and they don't have anything, like at first if they walk in, they just like, no lie, typically they walk in and they look like that.
Yeah.
Like, I don't know what you guys do. Well, what are you looking for? And we kind of embrace them, welcome in, and make them feel welcome. Sometimes I even put them to work. Go work the front desk. But I mean, because I want them to feel comfortable. And let me go back, because I heard Dr. Martin said something. Listen, we're here to work alongside you. And the reason why I do what I do is because, see, I'm a person in long-term recovery. And I remember when the courts ordered me to get counseling. And I went to this counselor, and because I projected my insecurity off on this counselor, I would not allow her to help me. I looked at her and I thought she was better than me. You feel me? And I thought that she would look down on me because I was a drug addict and because I was strung out. And so with that being said, when I bring along a peer support person, somebody that has lived experience, typically that person let down their guard because that person understands what this individual is going through, So what we do on a daily basis is, I can tell you, we opened January of last year, and since January of last year, we have seen, I think, 2,700 people in 1 year. We have sent over 600 to treatment, and we have had over 1,700 follow-ups.
Wow.
So I was looking up the rate for the jail. It's like $71 a night, $71.63 a night to stay in jail. So if you do the math for a month, that's almost like $2,000. If you do it for a year, that's almost like $25,000. So just imagine the people that we continuously get following up. You guys like your taxes? Do you? Well, we save you taxes, girl. All right. So what we do is we walk alongside these individuals. Like if we see them on a consistent basis and if they have charges, we go to court with them. We advocate for them. We go to the doctor's office with them. My people can meet them at the coffee shop. Y'all probably ain't able to do that, but our ethics allow us to do that. I will go to the gym with you if I have time. But we get them their license, their birth certificates. We take them to the Social Security office. We offer some transportation. Now, let me correct myself. We are not here to enable these individuals. We're here to walk alongside them. So if we see them doing what they need to do for their recovery, their life, because recovery, like Shawn said, is a life-changing event, If we see them doing that, then we're willing to walk alongside them. But if they're not doing it, I am not willing to give you a bus pass. I'm not willing to go above and beyond. So I think that these individuals are great individuals, and I think that they are doing an amazing job. And I know from my own experience that it works. And I wish that it was available when I was using, because I knew nothing about resources. Like nothing. I came from a small country town. Like I knew nothing about detox. I knew nothing about treatment. All I knew was that I can go to jail. And I seen the people go from the 2 to 5 month section. And I kept going to the 5-year section. You know what I'm saying? I was like, why? You know, and eventually somebody told me, well, they going to treatment. And so now I got individuals, and I learned something today because Dr. Martin said that when she was working at the emergency room, they was giving out old literature, old resources. So what I learned today is that all the EDs that's not in this room, my people are going to go out to those EDs after we leave next week, and they're going to give them some up-to-date resources, you know, because I want to help everybody. Now y'all ready to dance again? No, I'm just playing. All right.
Thank you, Shalinda.
Thank you.
If you guys want to know more about NEA, you guys can scan this too. So
We'll also make sure you all have her contact information. Okay, so we are running out of time on our section, so we're going to try to get... Yes. So Divine is one of our partnerships that are going to be deploying peers into the northeast region of the state. So some of you may actually be working with some of these peers. So this will be a great time to network and get to meet them. I actually have a map somewhere in the presentation. But okay, so peer supervising peers. Why do we have peers supervising peers and not clinicians supervising peers? It's because we are constantly defining and redefining the role, clarity, and scope of work. Understanding self-care and burnout, which is real for a peer because you're constantly re-traumatizing yourself. But staffing difficult cases, certification test prep, which is really important. You need to be learning from people that's went before you and finding out things that they've been through and what worked and did not work and having an opportunity to learn more. Ethics review and understanding.
and one that's not on there real quick is peers supervise peers so that we stay in a non-clinical role. Right? If a clinician is supervising a peer specialist, all the clinician knows is the clinical role. So it's difficult to teach someone how to not be a clinician than it is to teach someone how to be a clinician. So
Next slide, please. Okay, so we do weekly peer supervision, which is going to be held through ABIM with Shawn and myself. With the peers that are going to be working with you guys, this is what we're going to be providing. So they will not only work with their direct peer supervisor, but they will also work with Shawn and myself on a weekly basis to make sure that we're going over those difficult cases, finding out if there's something that's not working well, being that bridge between your facility and the peer. Daily supervision will be available through Divine Intervention for those in the Northeast. And then on-site supervision through point of contact established at the ED or clinic. So we need someone in your facility to be a champion for these peers and be a point of contact for them. Okay, here's the map. So you can see the stars are not assigned to an RCO yet. We're still working on another partnership to get you connected. Divine Intervention will be handling all the diamonds, so you can see your county on the map and know who you're going to be working with.